You're watching Houston MediaSource's WTP-TV, We the People Television's 24-hour coverage of World AIDS Day 2006. 24 hours of enlightenment, education, and hope.
Today we're going to be talking a little bit about pediatric HIV worldwide and the things that Baylor College of Medicine are doing to help with this problem. First slide, please. The Baylor International Pediatric AIDS Initiative was founded in 1996 to work worldwide with children with HIV. Unfortunately, next slide, please. Unfortunately, this that you see is still the face of pediatric HIV worldwide. While in the US, great strides have been made to treat children, in other parts of the world, many children are still dying from this disease. And we're going to talk today about who those children are and what we can do to change that. Next slide. In 2005, there were an estimate of 2.3 million children living with HIV. Anyone under 15 years of age is counted as children. In that same year, 700,000 new infections were reported, and there were still over 500,000 deaths. And so there still continue to be more children infected each year than are dying from the disease, which tells us that this epidemic continues to grow despite efforts to stop it. The vast majority of these children, over 90%, are infected from mother to child. So their mother is HIV infected, and it's during the birth process that these children become infected. Next slide, please. There are several countries in the world where the HIV rate among pregnant women exceeds 20%. These are Botswana, Lesotho, Zambia, South Africa, Namibia, and Swaziland. And as you can see, most of these countries or all of these countries are in sub-Saharan Africa. So this remains the region of the world where pediatric AIDS is the worst. Next slide, please. We can prevent transmission of HIV from mother to child. If absolutely nothing is done, then your transmission rate will be approximately 30%. So if the mother's given no medications and there's no intervention, about 1/3 of her children will be HIV infected. However, with medical intervention, which includes the mother taking medicines during her pregnancy, certain medicines given to her during delivery, and certain medications given to the child after it's born, we can actually decrease that rate to less than 5%. In fact, in most of the United States today, less than 1% of the children born to HIV-infected mothers are HIV infected. So clearly, the pediatric HIV epidemic is something that can be slowed. The problem is getting these medications to the women in sub-Saharan Africa and other parts of the world where it's needed. Getting the women tested can be an expensive problem. Getting the medications to them, getting the women into good prenatal care are all barriers that keep us from preventing the pediatric HIV. Next slide, please. This, however, is the face of pediatric HIV in the United States, and I like to show this to contrast it to the very first picture we saw. This is a young woman who is now almost 14 years old, who was born to a mother with HIV. She contracted HIV from her mother, but she has lived a very different life than those children born in sub-Saharan Africa and in Asia and in other parts of the world where these medications are not available. This young woman takes medications twice a day, every day, and she's been able to grow and thrive and remain healthy. In fact, just looking at her, you would never know that she had HIV. Next slide. But again, to do this means taking medications. So this is her breakfast every morning. It looks like a typical teenager's breakfast with cereal and milk and, of course, a soda. But the difference are the pills that you see there. And those are the medications that make up what's called the drug cocktail, or highly active antiretroviral therapy, or HAART therapy. It's these drugs that can firstly prevent transmission from mother to child, and secondly, if the child does become infected, can be given to children and keep them alive for a long time. Children who take these medications, like the young woman in the picture you saw, we feel can live to be adults, to go to college, to hold down jobs, and to even have families of their own. And so this is ultimately our goal for all HIV-infected children in the world. But the problem is getting these medications from the places in the world where they exist to places where they don't. Next slide, please. As Stephen Lewis, who is part of the UNAIDS HIV task force, said, in the instance of antiretroviral therapy, the scenario for children is quite simply doomsday. Children are not getting the life-saving medications at the same rate that adults are internationally. Next slide, please. And so what are the barriers? Why aren't the children getting these medications? Children are underrepresented among those accessing treatment in virtually every setting worldwide. There are an estimated 25,000 children receiving antiretroviral treatment in the developing world. This is fewer than 1% of all of the HIV-infected children globally. This is far lower than the number of HIV-infected adults globally who are receiving HIV medications. Next slide, please. And so as you see this young boy, he's at one of our clinics in Uganda. He quite simply cannot quite reach up to the pharmacy level, the window level. And this is the problem that children are having. Their voices are not being heard, and they're not quite making it into the pharmacy to get the medications the same way that the adults are. Next slide, please. So what are some of these barriers specifically? Lack of infrastructure is one of the biggest barriers we have. There simply are not places where the children can come for treatment. As places that treat adults grow, places that treat children worldwide are not growing at the same rate. There's a lack of and a loss of human capacity. There are very few pediatricians in the world, and there are very few pediatricians who treat HIV-infected children in the developing world. And at the same rate that other young adults in HIV-infected countries are dying from HIV, your nurses and your doctors and your pharmacists are also being infected with the disease, and so they're also unable to care for others. Medications for children are actually more expensive than the medications for the adults. There are less children who need them, it's more expensive for the companies to make them, and many of the generic drugs do not exist for children the same way they do for adults. There's lack of expertise on how to treat children. The medications for the children, while very similar to the ones for the adults, do need to be dosed differently, they need to be given differently, and the children have different side effects from the adults. And so people are often afraid to give the medications to the children because they don't understand the differences. The irony is that the children actually tolerate the medications often much better than the adults do. And so whereas many of the medications will cause the adults to have severe side effects, like nausea or vomiting or diarrhea or headaches, most of the children can take the medications without suffering these same side effects. And yet people are often afraid to give the medications to the small children. Next slide, please. So this was the face of pediatric AIDS in Romania when we first started working there in 1996. The children were wasted and sick and did not survive much past their 10th birthday. Next slide, please. And we started a clinic there. As you can see, our clinic was initially in someone's office. And we started with just simple treatments for the children, increasing their nutrition, bringing medications to treat the infections that they had because of their HIV and because of their weakened immune system. And slowly we were able to build the program in Romania to what you'll see on the next slide, please. This is the Romanian American Children's Center of Excellence. It's located in Constanța, Romania, which is a city right on the Black Sea in Romania. This is truly the epicenter of the pediatric HIV epidemic in Romania. Over the course of time, this center has treated almost 1,600 children and currently cares for 900 children who are rapidly becoming adults who are HIV infected. I told you at the beginning that most children are infected with HIV with transmission from mother to child. Romania is actually a little bit different. Here, these were many children who had been abandoned in orphanages who were given blood that was tainted with HIV when they were very, very small babies. And so here, the epidemic is actually a little bit unique. And you have a large cohort of children who under the former communist regime were infected who are now continuing to age. It's in this center that doctors from Baylor College of Medicine and doctors from Romania work together to provide antiretroviral treatment to these children. And we're able to provide through various grants, the medications, the same medications that the young woman who was climbing the tree takes. The children here have the same medications and are able to remain healthy and are living for a long time. Next slide, please. And you can see that very clearly here. In 1999, before the center opened, each year, 16% of the children would die from complications of their HIV. In 2004, last year, only 1% of the children died. This is basically the same rate that we see in the United States' best pediatric HIV centers. And so it tells you that even in a setting where many of the infrastructure is not there, where the healthcare system may not be as advanced as the United States, the highest quality of care can be brought to HIV-infected children. And once we proved that in Romania, the goal of Baylor College of Medicine was to continue to take this to other places in the world. Next slide, please. Botswana is a small country in southern Africa. The population is less than 2 million people, and yet they estimate that about 30% of the adults in Botswana are HIV infected today. And this number, unfortunately, continues to climb. Botswana is a little bit unique in that the government and the president of Botswana have taken a very active role in combating HIV. The government has not shied away from this, but talks very openly about it and has begun a program to bring medications and testing and care to the people of Botswana. Next slide. What you see here is an aerial view. The red roofs that you see are the Princess Marina Hospital. This is the main referral hospital in Gaborone, the capital of Botswana. And it's here where a partnership between this hospital, the government, and Baylor College of Medicine physicians has begun to help bring treatment to the people of Botswana. Next slide. And so there are many, many patients who need treatment in Botswana, and you'll see the patients begin to queue up early in the morning to receive their treatment. What was happening is while the adults were receiving treatment, there was no space and nowhere for the children to be receiving the same treatment. And many parents didn't want to take treatment until their children were treated. Next slide, please. And so in 2000, the Botswana Baylor Children's Clinical Center of Excellence opened on the campus of Princess Marina Hospital. This state-of-the-art center provides care to almost 2,000 HIV-infected children and their families today. It's through this partnership between the government of Botswana, the Baylor College of Medicine, and Princess Marina Hospital that we're able to bring these life-saving medicines to the children of Botswana. Next slide. The clinic rooms are friendly. You can see the paintings on the wall were all done by women from Botswana in traditional paintings that would usually be seen on the houses in Botswana in various villages, so that the people who come into the clinic feel comfortable and feel that it is actually part of their home and part of their country. Next slide, please. The waiting room is child-friendly with tables at the size of the children so that they have a place to play while they wait for their appointment with the doctor, so that the place does not become a sterile and frightening place for the children to be. Next slide. This is some of our staff. We have a full pharmacy staff there with well-trained nurses and pharmacists who help provide the care to the patients, who help teach the children about their medications so that they're able to take them every day. Next slide. And this is a classroom that's located at the center. The center doesn't only provide care, but it provides training so that other health professionals in the country begin to understand how to treat pediatric HIV and how to keep the children alive through these medications. And so we hold many trainings here for health professionals, not just from Botswana, but actually from all over sub-Saharan Africa. This place has become a true training center, and so physicians come from South Africa and Zimbabwe and Namibia and other centers to come here to learn about how to treat pediatric HIV and go back to their countries and begin treatment. Next slide, please. What we've seen early in this program is that we have 46 full-time staff working at the center, including 3 American physicians. There have been multiple people tested there, and we found that 38% are HIV infected. This is about in par with what they're seeing in the country. Currently, more than 1,400 children are receiving highly active antiretroviral therapy in the center in Botswana, making it one of the biggest centers for treating pediatric HIV in the world. And that's why so many people can come there to learn about treating pediatric HIV, because there are so many children being successfully treated in Botswana. Next slide. So where do we go from here? Now, Baylor College of Medicine, in collaboration with the various countries, has shown that you can bring world-class pediatric HIV care to some of the hardest hit areas in the world. But what was going to be our next step to continue to expand this? Next slide, please. And that's where the Baylor International Pediatric AIDS Initiative Children's Clinical Centers of Excellence Network was developed. The goal of this network is to have high quality, high impact, highly ethical pediatric and family HIV care and treatment to help bring medications and clinical research to international settings. The clinics are all designed to catalyze pediatric HIV/AIDS care and treatment globally, so not just to treat the children who are close to the center, but to do training and treatment of children from all over the countries. Next slide, please. And this is what our network actually consists of today. Our startings in Constanza and Gaborone, Botswana. We've now expanded to Kampala, Uganda, into Libya, into Malawi, and Swaziland, Lesotho, Burkina Faso next year, and hopefully China next year. And actually today, on World AIDS Day, our centers in Swaziland and Lesotho are both officially opening today. The folks in Houston, Texas supply support, staffing, training for the various centers around the world. And so our hope is through this network, we'll be able to truly effectively treat pediatric HIV worldwide. Next slide, please. This is actually the waiting room in our center in Uganda. And I think that this picture in and of itself speaks 1,000 words. So many people said to us, if you build centers that are known to be HIV centers, nobody will come because the stigma is so poor or so bad that people will be afraid to be known as HIV. But the families very quickly learned that by bringing their children to these centers, the children got the medications they needed, they got the best care in the world, and the children are growing and thriving and living. And so as you can see, the stigma did not keep the families away. And this clinic in Uganda regularly sees 170 pediatric HIV-infected children every single day. Next slide, please. And you can see the fantastic results that they've had at this clinic. The clinic started in full force in January of this year, and these statistics only look at the first 6 months when highly active antiretroviral treatment, or the drug cocktail, was available in Uganda. One would actually think that instead of seeing a decrease in hospitalizations and a decrease in deaths, one would anticipate an increase, because one would assume that the children who were started on the medications first were the sickest children, and by virtue of them being the sickest children, you would lose some of the children. But as a matter of fact, the medications did their job so well that even though it was the sickest children who started first, already in 6 months, we saw a decrease in hospitalizations and a decrease in deaths. And we're anticipating in the next 6 months, when those numbers come out at the end of this month, we will continue to see a further drop. And so this, like the slide that talked about the decreased death rate in Romania, you can see that getting these same medications that we have in the United States worldwide will clearly save lives of these children. Next slide, please. And so this site that you see here is where we will be building a new children's center in Uganda. Where the center currently operates is a place that's too small to be able to hold all of the children and all of the care that's needed. And so a new center is going to be built on this site here. Next slide, please. And this is a picture of the construction of one of the sites that opened today in Lesotho. Lesotho is a small country in sub-Saharan Africa, completely surrounded by South Africa. Like Botswana, there are less than 2 million people in the country, but it's one of the countries hardest hit by HIV. And so this center is being opened today by the King of Lesotho as a place to bring pediatric HIV care to the people of Lesotho. Next slide, please. And this is the clinic in Swaziland, which also, although a little behind on its construction, is due to open today. And as of this week, we'll start providing care and treatment to the children of Swaziland as well. Swaziland is another small country in sub-Saharan Africa, and it's actually the country with the highest rate of HIV infection in the world today. Next slide, please. This is the beginnings of our clinic in Malawi. Malawi is another sub-Saharan African country, completely landlocked except for Lake Malawi along the side. It's one of the poorest countries in southern Africa, and also will begin pediatric HIV care and treatment in the center as it's being built. Next slide, please. This, what looks today like just a blank piece of ground is actually in Burkina Faso. Burkina Faso is a country in Western Africa where mostly French and the indigenous African languages are spoken. And this will be our next site for a new center. And here we'll be treating children not only with HIV, but also with tuberculosis and malaria, as well as treating their family members for truly complete pediatric HIV care. This center is due to open in 2006. Next slide, please. So just as a recap, you can see here is a map of Africa, and the stars show you all the various places where there are going to be centers, or where there are already centers that the Baylor International Pediatric AIDS Initiative is working with the governments of these countries and with the physicians in these countries to bring world-class pediatric HIV care to the children of these countries. Next slide, please. But what is our next barrier? So now we've taken care of infrastructure. We're building the infrastructure that's needed to treat these children. But the next thing that you need are physicians and nurses and pharmacists who can help work in these buildings and take care of these children. And why are there so few health professionals in Africa today? Part of it is that there are not very many medical schools within Africa, and the number of graduates is not keeping up pace with the number of physicians that are needed. There are also a great deal of African professionals who leave the continent. They have their training, they're well-trained physicians, and they're frustrated by the lack of infrastructure and the lack of health care available for them to be allowed to treat their patients. And so they're recruited by the United States and European countries to treat children there instead. And so you have physicians who are trained and nurses who are trained in Africa who then leave to work in Western countries for better pay and better conditions. Of course, you have death of the health professionals from HIV/AIDS, the same as in any health profession or any profession in Africa today. They're losing numbers to this disease, same as teachers and bankers and everything else. And then there's just the crushing burden of care and treatment posed by HIV/AIDS and other diseases. And perhaps in a society where people were generally well, you now have a large part of the children and the adults who are sick and need care. And when you are in a situation where you as a health professional can do very little for these people, it becomes very difficult to continue working day in and day out. Next slide, please. In the United States, there are 106 pediatricians for every 100,000 children that are being treated. As you can see, this number is remarkably different from some of the other places where we're going to be working. In Lesotho, prior to the Baylor College of Medicine beginning to work there, there were 3 pediatricians in the entire country. Now, thanks to Baylor and new programs, there are 6 pediatricians, which still may not sound like a lot, but it's a doubling of the number of pediatricians who are available. And so you don't even have enough health professionals who are comfortable with the care and treatment of children in the countries. It's very difficult to treat them for regular childhood illnesses, let alone for more complicated illnesses like HIV and AIDS. Next slide, please. So what does Baylor propose to do about this? We've had the development of something called the Pediatric AIDS Corps, and this was announced on June 27th of this year. This program is a collaborative program. It's being funded by the Bristol Myers Squibb Foundation and by Baylor College of Medicine. And much like what the Peace Corps does, the Pediatric AIDS Corps' goal is to bring well-trained health professionals into the African setting. Next slide, please. The physicians who will be recruited are pediatricians as well as internists and family practitioners who have completed their 3-year residencies here in the United States. So they're what are called board-eligible or board-certified pediatricians. We're going to have 50 on the ground each year. Each one of them is going to be attached to the 6 pediatric centers in Africa that are being developed. They won't all work in the center. Some may work out in rural areas, but they will be attached to the center for support. We're asking them to make at least a 1-year commitment, and most of these young pediatricians are willing to make a 2-year or 3-year commitment. They'll all be trained in tropical medicine and in HIV, so they're prepared to treat the different diseases they're going to see in Africa. They'll be supplied with a living stipend, they'll be supplied with a housing allowance, and perhaps most important for some of these young physicians, loan debt repayment for the students. Your average debt for a graduating medical student is somewhere between $60,000 and $80,000. And so it's no small thing to spend 2 years of your life after you finish your training in Africa, perhaps earning a lower salary than you could in a suburban private practice. And so in order to assist these young physicians, we're going to help them with some of those loans. Next slide, please. The goal is to provide primary pediatric and HIV care and treatment to at least 80,000 African children and their families. Our goal is to provide the highest level of care as well as training to health professionals in the treatment of pediatric HIV/AIDS. The AIDS Corps hopefully will not become a permanent part of the African setting, but a stopgap between now and when there can be enough well-trained African physicians to take care of these children, as well as nurses and pharmacists. The idea is to dramatically expand the access of African children for HIV and AIDS care. Next slide, please. Currently, we've recruited 35 physicians, 31 Americans and 4 Canadians. Most of these physicians have graduated from top academic institutions and are trained in pediatrics, family medicine, or internal medicine. Many of them have public health degrees already or have additional training in infectious diseases and tropical medicine. Our recruitment continues, but as of August of 2006, we will have these 50 new physicians on the ground in Africa. Next slide, please. The last thing I want to talk a little bit about is research. I think that HIV research in many parts of the world has had a difficult past, and oftentimes people are concerned that when an American institution is working in a developing setting, that their main reason to do that is to develop research. That's certainly something that we do, but it's not our main goal. Our principal focus is care and treatment. Any research that goes on needs to be high impact, meaning that it's going to, the questions that are answered through the research is going to help those who are participating in the research. And so that any research that happens will assist those people who take part in the research. It has to be of the highest quality. It has to meet all international as well as American standards. It has to be ethically unassailable. There should be nothing about these clinical trials that at any time would ever bring anyone to question that children are being tested on or experimented on in another country. Any research going on in an African country should be the same research that you would conduct in the United States, the same research you'd be willing to have your own children take part in. And if that's not the case, then it shouldn't be done. It should be locally relevant, as I've already said, and it should advance care and treatment objectives, so it should make it easier and better to provide care and treatment in a developing setting. Next slide, please. So what are some of the research projects that are ongoing in the network? We're looking at operational aspects of pediatric HIV care and treatment in both Romania and Botswana, as these are our oldest centers, trying to understand what's worked well and what hasn't worked well, and so we don't remake the same mistakes in the new centers. Looking at HIV and hepatitis B co-infection in children, particularly in Romania. Trying to look at strategies for adherence and strategies for prevention of mother-to-child transmission. We want to look at the oral complications of HIV. In a child who needs to eat calories to grow, some of the most devastating problems can be sores in their mouth, so they're unable to eat, they're unable to gain strength and fight this disease. Looking at some of the different weight-based antiretroviral dosing. How can we make dosing of children easier so that health professionals without specific pediatric training feel comfortable using these medications? And lastly, trials called the Bana trials. Bana means children in Setswana, which is the language spoken in Botswana. And these are trials looking at the use of already approved medications in the United States in slightly different ways to improve the cost effectiveness and to improve their treatment of children in Botswana. Next slide, please. Last, I'd like to thank some of the many funders that we have who have helped Baylor College of Medicine as well as our collaborators in the various countries to be able to bring these programs to these children. The Bristol Myers Squibb Foundation, the Abbott Fund, the United States Centers for Disease Control and Prevention, the Fogarty International Center, and the Center for AIDS Research. It's through the help and support of these various groups, both private and national groups, that have allowed Baylor and our partners in each of these countries to develop these new programs to save the lives of HIV-infected children worldwide. Next slide. Thank you. We're going to take a bit of a break now, and later on we'll be taking some questions.
You're watching Houston MediaSource's WTP-TV, We the People Television's 24-hour coverage of World AIDS Day 2006. 24 hours of enlightenment, education, and hope.
Okay, I think we have a caller. In just one moment. I'd like to thank...
Caller, what's your name and your comment? Say caller, what's your name and your comment?
Caller, I don't think they're here yet.
Hello?
Caller, what's your name and your comment, please?
My name is Brian. Dr. Schwarzwald, the reason for my call is I have two questions for you. The first one being, why sub-Saharan Africa? Why is there such a intensity of this disease in sub-Saharan Africa versus anywhere else in the world? And I have one other question, that being, I recently had an opportunity to see a movie called The Constant Gardener, and the pharmaceutical companies were shown off in a very negative light. I'm not sure if you're familiar with this movie, but I'm wondering what your thoughts are as far as drug company performance with this disease in Africa.
Okay, well, thank you very much for your questions. The first question that I'd like to answer is, why sub-Saharan Africa? That is a very good question. We know that certainly the highest number of HIV-infected persons is in sub-Saharan Africa. And I think there are several reasons for this. First, the HIV infection spread very quickly in this area because of many of the ways that commerce takes place in sub-Saharan Africa. Much of commerce is distributed along truck routes, and we found that it was unfortunately many of the truckers and the commercial sex workers who the truckers were utilizing that helped increase the spread of HIV. In addition, many of your poor families were forced to be separated. The men and the women from the family were separated in order to find work. And so again, the use of commercial sex work and the spreading of disease through these ways are one of the main ways that HIV spread. There's been some question about whether the particular type of HIV in sub-Saharan Africa is actually more virulent and more easily spread, although that has not been shown definitively. And so these are some of the reasons we think why HIV has increased. Of course, unfortunately, poverty and warfare and homelessness are all problems that have been faced by some of the countries in sub-Saharan Africa and have increased the HIV. As to your second question, I am familiar with the movie, and I don't know if others of our viewers are, but essentially this particular movie implied that the drug companies were utilizing patients in Africa for testing of medications without their consent. Certainly I can't speak to the movie. It was a fictional movie, and so I can't necessarily speak to what was done in that movie. I do know that our experience has been very different from that, and that always the research has been of the highest standards and the highest quality, and has, again, like I said, has been utilized to answer questions that are important to the people who are participating in the research. And so that any research that goes on in our institution, certainly, and in most places in sub-Saharan Africa, has as a goal improving the treatment of the care and the children who are in sub-Saharan Africa. Does that answer your question, sir?
Yes, it does. Just one other quick question. I really thank you for your time. There has been, I've heard of, or read some articles regarding generic drugs that are being produced in India for a distribution within the sub-Saharan African areas, drug or HIV-infected areas. And I understand that these drugs are produced at a reduced cost or made available into these markets at reduced prices, or certainly under the U.S. or Western country produced drugs. If you could just comment on that, and I'd like to thank you for your time.
Certainly, I'd be happy to comment on that. There are indeed medications that have been produced in India, and many of these medications are actually easier to take than some of the traditional medications, because they'll have 3 medications in a single drug. Unfortunately, what's happened with some of the medications, although not all of the medications, is that they have not been put through the same rigorous testing that some of the brand name drugs have been. And so while many of these drugs are very high quality and can certainly provide care at a reduced rate, and therefore, of course, more people can be treated with the same monetary budget, some of the drugs have not been put through rigorous testing. And so the World Health Organization and the Federal Drug Administration in the United States are actively working to make sure these drugs are tested properly so that they are safe and secure and can be used. As a pediatrician, the biggest problem that we see is that the companies are not producing these generic drugs for children. And so whereas adults at this point can take often one pill in the morning and one pill at night and still get the same drug cocktail provided by the many pills that were sitting next to that young girl's breakfast, children don't have access to this same care. There aren't liquids that are produced that have the 3 drugs in one. There aren't pills that are small enough for children that have the 3 drugs in one. And so physicians in many developing countries are being forced to guess at the dosing for children and cut the pills in half or in quarters, try to put them into solutions. And in that way, unfortunately, you cannot guarantee that the children are going to get the adequate dosing. And you may treat their disease for a little while, but they may develop a resistance to the medication. Just like with an antibiotic, if you don't take your full 10 days of the antibiotic, or you don't take as much every day as your doctor has prescribed, the risk is that instead of curing your infection, you'll actually develop an infection resistant to that drug. Much like we see problems with resistance to amoxicillin today, the concern is that these children will develop resistance to these medications and will not have the long-term effects that we're hoping for. And so part of what our group and what Doctors Without Borders has been working for is to encourage these companies to continue to develop drugs that are good for children and can allow children the same easy access to medications that adults have. Thank you. As we're waiting for other callers, perhaps I can comment a little bit on some of the other issues that we see with pediatric HIV. As I mentioned in the very beginning, most of the children become infected with transmission from the mother to the child. And so there are many ways where this can be incredibly difficult. In many of the countries where we work, the women do not necessarily have the same choices that they might have in a country like the United States. I was blessed with the choice to go to medical school and become a doctor, but many women are not given the choice even to go to school or to elementary school. And so they don't know much about HIV. And so when they're pregnant, they may or may not seek care in a hospital. And if they don't seek the care, the concern always is that they'll not be tested for HIV. And if we don't know they're HIV infected before they deliver the baby, we can't prevent the transmission of the disease from the mother to child. Even if we do know they're infected, getting the medications to the mother in a timely manner, making sure she has enough for her entire pregnancy, it can be a challenge as well. I think we have another caller on the line. Hello, can you tell us your name and your question, please?
Hi, Dr. Schwarzwald. My name is Tom Gaggany. I'm with the Center for AIDS Information and Advocacy here in Houston. I had a question. I recently came back from a conference in Mexico, national conference, and became really highly enlightened about some of the different problems that people in other countries are facing. And obviously you illustrated a lot of that in a couple of the slides that you showed. One of the things that I had a question about, I became familiar with a recent report by a new group called, I think it's the International Treatment Preparedness Coalition, and they did a country-by-country report card on sort of looking at the World Health Organization's 3x5, meaning treat 3 million people by 2005 initiative. And of course that they were not able to reach that goal. However, they're looking at reasons why, and obviously it's a very, very multifaceted situation, touching on a lot of the themes you talked about in terms of shortages of healthcare professionals, and in terms of infrastructures in countries and other things. And so I'm wondering, as you're building what is very apparently really quite an impressive network, I'm wondering about what are the long-term things that you want to put into place to make sure that these efforts are sustainable, and because even the pediatric AIDS score that you described is a 5-year kind of timeline, and who are you talking to in terms of, and who else are you working with in terms of government or other groups to try to ensure that this continues to have momentum, and that your efforts won't be for naught. Obviously, it's having great impact already, but so much more is needed. And how do you think we can kind of get a snowball effect?
Okay. Well, thank you very much for your question. Certainly, I'd like to start first by addressing what are we doing to sort of try and sustain the programs that we've already started. And you're absolutely right. The World Health Organization had committed to treating 3 million people by the year 2005. And unfortunately, that goal has not been reached this year. And many people are looking at why exactly. And as you said, many of the reasons we talked about here today are some of those reasons. So there are a couple things we're looking at to try and make these programs sustainable. First is that all the programs are done with the government. And so they're not done in isolation. Everything that we do is part of the government's national strategic plan for HIV in that particular country. So for instance, in Botswana, while the center was built through private funds and many of the doctors are volunteers or paid physicians from the United States, much of the health professional are also Botswana government employees. And so the hope is that through these centers and through the AIDS Corps, we'll continue to train physicians who will then be able to take over as these things are phased out. What we've also found already is a reversal of what we call brain drain. And as I talked about, African physicians have been leaving, as well as nurses and pharmacists have been leaving Africa for the United States and for European countries. And what we've actually found is that with the beginning of these centers, physicians are coming back. And so for instance, in our center in Lesotho, we actually have 2 pediatric physicians, both who trained in the United States and have lived in the United States for a long time, have actually returned to Lesotho and are going to be working in the centers there. And so that's part of what we want to do to make these programs sustainable. The HIV medications that are provided in these programs are provided through the government or through the World Health Organization or Global AIDS Fund. And so those will continue to be provided regardless of the continuing of our program. So those are some of the things. And then again, we don't own the buildings once they're built. They're owned by the governments there. And so the hope is the collaboration between public and private and academic institutions can continue to encourage more Africans to train to be physicians and more Africans to come back to their countries who have trained in other places to provide that care.
Great. Thank you very much. One follow-up question, if there's not too many people waiting.
No, go ahead.
Very quickly, in that report that I mentioned, there were 6 countries identified as the most hit by the epidemic in terms of the need for treatment. And so they're going to be reporting on other countries, but I think the 6 that they looked at were, I think, Nigeria, South Africa, one more in Russia. I'll think of it in a second. Maybe Uganda, and then India, Russia, and Dominican Republic. And one of the questions I had is, obviously many of your centers are happening in Africa where there is tremendous need. Are you looking at, or have you started any talks with for instance, other places in Eastern Europe or Russia or India, or even looking in the Caribbean? Many places in Central America and the Caribbean often feel ignored. There has been some progress in South America, not all countries, but Brazil certainly is a leader in that regard to getting treatment to people, and Mexico has kind of been better than most, but still, like I said, has its challenges. And so I'm wondering, are you also expanding the scope or looking to perhaps encourage other groups to participate, other universities or other networks to try to establish things in other places as well?
Yeah, that's a wonderful question also, thank you. Actually, what I failed to mention is some of our earlier programs actually did take place in Mexico, and we do still do some work with health professional training there, although we don't have a center necessarily. I agree with you that much of Latin America and the Caribbean often feels ignored, and we currently don't have plans there, but certainly would be very happy to partner with other partners to begin to work in those areas. As for Eastern Europe, we do have the center in Romania, and certainly we have had discussions with folks in the Ukraine and also in the former Soviet Union and Russia, and hopefully we'll be expanding to develop programs in those areas. There actually is a very good pediatric HIV center already in St. Petersburg, and so perhaps working with them as well. And then lastly, you mentioned India. And although we're not currently working in India, India and China actually have similar epidemics today, whereas perhaps their percentage of HIV-infected persons is not as high as in other places because of obviously the huge populations they have. It still amounts to a large number of people who are HIV-infected. And so just last month, we actually signed an agreement with a group of physicians and the government in something called Yunnan Province, which is in southern China, and we'll be building one of our next centers there to start to address some of the same issues in Asia as well. As you mentioned, Eastern Europe and Asia have some of the fastest growing epidemics, even though still more people are affected in sub-Saharan Africa than anywhere else in the world.
Well, thank you very much. Your presentation has been very informative, and it once again makes me proud to be a Houstonian, seeing what groups like Baylor College of Medicine can do across the world. So thank you.
Thank you very much for your questions. It's a pleasure talking to you.
Bye-bye.
Bye-bye. we were talking a little bit before that call about transmission of HIV from mother to children and some of the barriers there are to preventing that. I think it's important to understand, though, that as treatment expands, one of the first places that it's being expanded is in prevention of mother-to-child transmission. And there's a group called the Elizabeth Glaser Pediatric AIDS Foundation that has taken a leading role in preventing mother-to-child transmission. And so as this prevention can happen, our hope has always been that there will be less and less HIV-infected children. Unfortunately, though, it will be a while before these mechanisms are in place, and so there will continue to be children born to HIV-infected moms who are HIV-infected. Lastly, I just want to mention briefly those children who are not HIV-infected, but still born to HIV-infected families, and these are the AIDS orphans that you'll often hear about. They talk about somewhere near 20 million children who are not HIV-infected, but HIV-affected. And these are a group of children who desperately need our help. Because they have lost one or both parents to HIV, they are left without the fees they need to go to school. Particularly, unfortunately, the female children or the girl children are less likely to have the money for uniforms and for school fees. They're often taken in by aunts and uncles and grandparents, but it can become overwhelming. On a regular basis, we hear about grandmothers who are taking care of 15 grandchildren because they've lost more than one of their children to HIV and AIDS. And so this woman with limited income is trying to just feed and clothe these children, let alone get them into school. And so you have a generation of children who may have escaped becoming HIV infected from their mothers, but then are thrown into poverty with a lack of education and often find themselves forced to take part in commercial sex work or other activities to support themselves and their families, and then become at risk of becoming HIV infected as they enter puberty. And so this is a group that needs support from everyone in the world and from all the volunteers to provide food and clothing and education so that we don't lose a second generation to HIV. I'd like to thank you very much for your kind attention today and for the wonderful questions we received. Again, if anyone has any further questions, we can be reached at bayloraids.org on the website. And I hope that this one day today will this one day of World AIDS Day will bring more awareness about the HIV problem and more people working towards it.
Hi, I'm Stacy Hewitt. I'm standing in front of People with AIDS Coalition of Houston. In recognition of World AIDS Day, I've been granted a tour of the facilities by one of the administrative staff. Let's take a look. Morning.
Actually, I'm Naomi Doyle-Madrid. I'm the Executive Director of the People with AIDS Coalition Houston, Incorporated. And this is our agency. So our agency was founded in 1986, and it was founded on the warehouse program, which is what you're kind of in the middle of right now. The warehouse program provides household items and furniture and clothing for people living with HIV disease in the Houston, Harris County area. And this is the room where we have our clothing. Some small houseware items are here. Clients come here to shop, and they can come twice a month. We have a commercial moving truck that does pickups and deliveries of the larger items. This is our house. We own this house. We merged with an organization called Milam House in 1999. They had purchased the house in 1995. And so we moved in August of this year. It used to be a part of a transitional housing program, but now it's where we have our administrative and social service programs. So this is actually an old Victorian house. It's like 70-something years old, so you'll see some really unique pieces to it. We come through here. We have the foyer that we would do primary meetings for the board of directors. We have a support group room through here. There's a support group going on right now. It would be what historically is considered the living area. We do education it's prevention education for positive people. And we have probably about 2 or 3 groups that go on, sometimes per day, to maintain their levels of confidentiality, though we try to maintain closures so that people can't see who's in there and what's going on. So if we're still here, we can head into that room when they're finished. This is our stairway heading up. Most of the offices for the staff. A unique piece, we kind of are redoing the house. It has some structural issues, I'm not going to say damage. One of the things we did when we moved everybody in here was we allowed every department to determine what color paint they wanted to paint their space. And so that they would feel like they own their space a little bit better. So you're going to see some pretty bright, interesting colors in the house. And we've had, the clients seem to like it. So that's been a big plus. So I'm going to walk you through our space in here. This is my office. As you can see, riddled with papers, very unorganized. This is the life of an executive director. It's not glamorous in any capacity. Well, at least my life is not glamorous. We'll be walking through some restrooms. We have, since it was a house, it's a full, we have full bathrooms. We have 3.5 or actually 3 bathrooms upstairs and then 2 downstairs. This is our adolescent program. We fund it through Ron White Care Act Title IV. We do adolescent case management, outreach, and education. And this is their office space. They like the color orange. We have a lot of children in the program, so you'll see random toys because we're getting ready for the holidays as well. So we provide toys for kids and families. This is our, what would be the sunroom if you lived here. It's our server room. It has an extra table. We're reorganizing this room because that's actually a working elevator. So we're going to make this into another sitting area to be able to meet with clients if necessary. And we're going to get rid of some of these tables and kind of reorganize it. We're also painting this room red. This has not been painted yet. We come around. I do have a staff member in here who does not want to be videotaped.
Oh, okay, turn it off.
He just doesn't want to be videotaped if you can make sure you don't get him.
Okay,
This
I'll
is
turn it
our
out.
Department of Education office. We do prevention for positives, secondary prevention education, and what some people consider that to be funded through the CDC via the City of Houston. And we have, this is where they meet, and they're the ones who primarily conduct the support group activities. We have to go all the way around because we're getting ready for the holidays. We're getting our holiday stuff up. I also have additional staffing in here who they, if possible, would not like to be videotaped.
Okay.
Maybe not. I don't know. You could.
I'll just focus on you.
Lauren, it doesn't really matter. I know it doesn't matter.
Okay.
This is our finance office.
Okay.
Our lovely volunteers. I don't know if he wants to be videotaped, but this is our kitchen area as well. And so we utilize this kitchen, of course, for staff. Did you make more coffee? Yeah. Thank you so much. For our staff, we had a wonderful Thanksgiving holiday party last week. Wow. Beautiful. We cook periodically and stuff like that. I would like for you to see the support room, but can we do it without showing clients? Is that possible? Can you not video? Can we try to hide?
We're not making you run. So bad.
So this is the education support room, which in the house would be considered the living area. It's our largest area to greet and meet. And all the furniture that you see in here has actually been donated. We really don't purchase. The only thing we've purchased so far are the desks upstairs for the staff. Everything else is donated to the organization. So we do take mass or donations. Commercialized truck for the warehouse. It was purchased through the Houston Endowment Foundation grant. And the house is really quite magnificent. And it's, I think probably the most magnificent part of it is that it's ours. It needs some work, but over time. It's definitely nice being in a house setting providing services. We've had a lot of positive reaction from clients. They don't feel like they're going into a clinical setting. They like the atmosphere. I think it helps them deal with some of their health issues a little bit better. But we're happy to be here. Hope to be here for a while longer. That's it for me.